Morning, sir. Loud and clear. Morning, everyone.
Okay. All right. Excuse me. We're at the beginning of week 2. So we'll be covering 3 modules this week and start a new one, right? So we have three modules to cover this week, and we will be starting traumatic emergencies as well. It's going to be a hectic week. This week I'll be moving I'll be moving a lot faster than I did last week. They need to ensure that you keep up. So the first module we're going to look at for this week is airway management. We will also be covering patient assessment and shock. 3 very important modules. And we're starting with airway management. Airway management is going to be one of the most important skills that you have to learn and become proficient at as an EMT. The proficiency will be based on your ability to assess the patient properly, recognize what the problem is, and determine what's the most appropriate management, and be able to use the equipment effectively that is required. If you cannot fix an airway issue, the patient viability decreases significantly. So if you don't have an airway, nothing else matters. Let us begin. All right, so topics that we'll be looking at: airway physiology, airway pathophysiology, opening the airway, airway adjuncts, suctioning, keeping an airway open, definitive care, and special considerations. All right, so let's review the airway physiology. The upper airway begins at the mouth and nose. Air is warmed and humidified in the nasal turbinates, that's bones inside of the nose. Pharynx consists of the oropharynx, nasopharynx, and laryngopharynx. And the pharynx is the posterior portion of the throat, and it ends at the glottic opening. The lower airway begins below the larynx, composed of the trachea, bronchial passages, and alveoli. Alveoli are tiny. These are tiny sacs in grape-like bunches at the end of the airway, surrounded by pulmonary capillaries. Oxygen and carbon dioxide diffuse through the pulmonary capillary membranes. All of this is stuff that you should be very familiar with at this stage. So the airway pathophysiology. A variety of obstructions interfere with airflow. It can be foreign bodies, food, small toys that will be more common in your pediatric population. Liquids, blood, vomit. Obstruction may also result from poor muscle tone caused by altered mental status. So if there is a decrease in brain function, it will affect the patient's ability to keep their upper airway patent and also ventilate adequately. Obstructions can be acute or chronic. Acute means sudden. That's what the word acute means. Chronic means it occurs over an extended period. Example of that would be somebody eating, not chewing the food properly, talking, and it ends up into the ear passage, causing a sudden obstruction or acute obstruction, right? Chronic would be a patient with a respiratory problem over the years that has caused issues with the bronchial airways or the alveoli. It affects the air exchange in and out of the lungs and the diffusion of oxygen and carbon dioxide. That would be chronic. Providers must initially evaluate airway and monitor patency over time. Airway obstructions, acute, foreign bodies, vomit, blood. Occurring over time, edema from burns, trauma, or infection, decreasing mental status. Airway obstructions, bronchoconstriction, or constriction of the lower airway. Disorder of the lower airway, smooth muscles constricts internal diameter of the airway. So when there's bronchoconstriction within the lower airways, air is still able to get into the lungs, but the patient is going to have trouble getting air out because of the narrowing of the air passage. Right now, the patient assessment phase. Once there is a airway issue, it must be managed in the first phase of your assessment of the patient. We call this the patient assessment. In the patient assessment phase, this is referred to as a primary assessment. When you're managing the airway, it must be done in the primary assessment. You cannot move on to anything else until you have addressed airway issues that are life-threatening. So addressed in the primary assessment, 2 questions must be answered. Is the airway open? Will the airway stay open? Very important questions. Is the airway open? In most patients, can be determined by simply saying hello. If the patient is able to communicate to you, airway is open, right? What if you say hello to the patient doesn't respond, you apply pain, patient groans. Is that patient airway open? That's a question. Anybody want to try and answer that question? Yes, Mr. Manning, go ahead.
Yes, sir. The airway would be open because they responded with a groan. It's just that they're not fully aware. They're just
Okay.
reacting to stimuli.
So the next question to you, Mr. Manning. Is this airway adequate? If you apply pain and the patient groans, is this an adequate airway?
No, sir. I would not say it would be fully adequate.
How would you determine if it's adequate?
Well, you would determine if it's adequate by assessing the rise and fall of the chest to see if it's, we call it a tidal volume. The you just assess if they're breathing properly, if there's adequate rise and fall, if they are ventilating properly.
Okay, I hear you. So this is what I want going forward. So you're not incorrect. You're correct, but there's no sequence to what you're saying. So going forward, when I ask a question like, how would you determine if the patient's airway is adequate? One, is it a upper Is there an upper and lower airway? Yes. If it's the upper airway, you position the airway, make sure it's clear, look, listen, and feel. That's it for upper airway. If it's the lower airway, we're looking at ventilation, oxygenation, and respiration. Therefore, you must evaluate rate, rhythm, quality, depth, pulse oximetry. Must listen to lung sounds. So it shouldn't be something that you are thinking about going forward. You need to have a sequence to assess your patient. That's where we're going. So you shouldn't be thinking about what you need to do to determine if somebody's airway is adequate. It should be second nature based on the sequences that you're following. All right, so is the airway open? In most patients, can be determined by simply saying hello. Sniffing position seen when swelling obstructs airflow through upper airway. You will see sniffing position in your pediatric population, right? Seen when swelling obstructs airflow through upper airway. So the head kind of tilt back, that's a sniffing position. So findings that indicate breathing problems, inability to speak, definitely having a airway issue. Unusual raspy quality to the voice, that could be concerning. Stridor. Stridor is a high pitch whistling type wheezing sound that is heard without putting a stethoscope on the patient's chest. They don't need a stethoscope to hear stridor. This is an indication that your patient may have an upper airway obstruction. That is going to be life-threatening. Snoring, you're thinking about the tongue at that point. Gurgling, that's blood or fluid inside of the ear passage. Will the airway stay open? So is it open? Will it stay open? These are the two questions you need to answer. Airway assessment is not just a moment in time. Must give constant consideration. It is something that is ongoing. Signs of inadequate airway. No signs of breathing or ear movement. Evidence of foreign bodies in the airway. No ear felt or heard. Inability or difficulty speaking. Unusual hoarse or raspy voice. Absent, minimal, or uneven chest movement. Abdominal breathing can be concerning. Diminished or absent breath sounds, that is concerning. Abnormal noises such as wheezing, that's lower airway obstruction, bronchoconstriction, crowing, that can be linked to upper airway stridor, upper airway snoring, tongue, gurgling fluid, or gasping during breathing. If you're seeing agonal gasp, that's not considered breathing. So you will treat that patient as if they are not breathing. Now, in your pediatric population, you need to be looking out for nasal flaring. You need to be looking out for retractions above the clavicles. All right, now opening the airway. Patient care. The airway, when primary assessment indicates inadequate airway, a life-threatening condition exists. Take prompt action to open and maintain the airway. So it starts with your assessment. You will approach the patient, you communicate to the patient. Hello, sir. Hello, ma'am. My name is Mr. Rufus. I'm a medic. Can you hear me? You don't get any response to verbal, you apply pain. Patient doesn't respond to pain, your patient is unresponsive. If your patient is unresponsive, it means that there is a airway issue, because once your patient goes unresponsive, the muscles that control the tongue will relax and obstruct the airway, and the tongue will obstruct the airway. You now need to move that tongue out of the airway using mechanical procedures. You will either do a head tilt chin lift or a jaw thrust maneuver. Head tilt chin lift is for your patients with no spinal injury. Jaw thrust maneuver is for patients with suspected spinal injury. So the next phase would be to open the airway. Once you open the airway, you need to verify that there is no foreign body inside of the airway, no fluid inside of the airway. You look, listen, and feel. If your patient is unresponsive, look, listen, and feel simultaneously. Check for a pulse. Opening the airway. If airway is not open, use positioning to open it. Indications of head, neck, spinal injury. Mechanism of injury known to cause such injuries. Any injury at or above the level of the shoulders. Family or bystanders give information leading to suspect it. Right, so to determine if you may have to use a jaw thrust for your patient, you will evaluate the mechanism of injury. Now, in EMS, the mechanism of injury is specific to trauma patients. It is anything that caused the injury to the patient. So whatever caused the injury is the mechanism. Was it a gunshot? Did the patient fall from a tree? The patient fall from a tree. Was the patient involved in a motor vehicle accident? So whatever caused the injury is the mechanism of injury. When you're evaluating the mechanism of injury, you need to determine if this mechanism of injury is diffused or localized. Diffuse meaning, did the energy involved spread throughout the body? Localized mean, was it specific to one point of the body? Once a mechanism is considered diffused, you must suspect spinal injury for your patient until it is ruled out. If the mechanism is localized, then you focus on the point of injury. Opening the airway, head tilt chin lift maneuver, and the jaw thrust maneuver. Move airway structures into position, allowing air movement. Right now, pay attention to the positioning of the fingers, right? You don't want your fingers in the soft portion of the chin or throat. You want to manipulate the mandible, right? And you control the head. That's your head tilt, chin lift. So place one hand on the patient's forehead and fingertips of the other hand at the center of the patient's lower jaw. Tilt head, lift chin, do not allow mouth to close. So the jaw thrust maneuver is when you suspect spinal injury. You're manipulating the joint within the mandible, temporomandibular joint. So you're pushing the mandible up, and then you're using your thumb to push it forward. It's up and push forward. And By doing that, all you're manipulating is the lower jaw. And in doing that, you pull the tongue out of the ear passage without causing any significant movement within the neck or spine. To keep the patient's head, neck, and spine aligned, moving patient as a unit into the supine position, kneel at the top of the patient's head, place one hand on each side of the patient's lower jaw, at the angles of the jaw below the ears, stabilize the patient's head with your forearms. Using index fingers, push angles of the patient's lower jaw forward. You may need to retract patient's lower lip with your thumb to keep the mouth open. Do not tilt or rotate the patient's head. All right, now airway management. After airway has been open, position must be maintained to keep airway open. So once you open the airway in the field, in real life, because you're not gonna see this with the mannequins when you're practicing. In real life, when you open a patient airway, once you let go of that patient's airway, it's gonna close. So you have to maintain it. Right? So once you do a head tilt chin lift and release it, the airway closes back. You do a jaw thrust maneuver and let it go, the airway is gonna close. So once you have opened the airway, you need to ensure that you keep it open, right? If that's not possible. And you're gonna be using your airway adjuncts for that purpose. So that's the purpose of airway adjuncts, to maintain the airway so that your hands are free to utilize other equipment. Airway must be cleared of secretions and other obstructions. So let's look at the airway adjuncts now. So airway adjuncts, airway positioning and maneuvers are short-term solutions. Again, once you have positioned the airway using manual maneuvers, once you release those maneuvers, the airway is going to close. And if your patient is unresponsive, they can't keep their airway open. You have to open the airway, maintain the airway. This is where your airway adjuncts come into play. And the two most common airway adjuncts that you will use as an EMT is an oropharyngeal airway and nasopharyngeal airway. Oropharyngeal, or OPA, goes inside the mouth. Nasopharyngeal airway, or NPA, goes inside the nose. Now, rules for using airway adjuncts. The OPA, in order to determine if your OPA or NPA is needed, or your oropharyngeal airway or nasopharyngeal airway is needed, you must assess the patient for its indication. You cannot use the airway if you have not assessed to determine if it is indicated. You must assess the patient for its indication. One, if it's an OPA, your patient must be unresponsive. The patient must be unresponsive. Two, there must be no gag reflex present. Gag reflex is your vomiting reflex. So if something goes too far into the back of the mouth, you'll gag and you vomit, right? So the patient must be unresponsive, no gag reflex must be present. And the third thing is the patient must be having a ventilation problem. I'm gonna repeat that. One, for your OPA, patient must be unresponsive. Two, there must be an absence of a gag reflex, so no gag reflex must be present. Three, there must be a ventilation problem, meaning your patient is breathing too slow, too irregular, no breathing. So there must be poor chest rise present. That's a ventilation problem. If these three components are not assessed, you cannot determine if you need to use the OPA. And if these three components are not assessed, being evaluated for airway management, you will fail the skill station. Cannot manage what you have not assessed. So that's OPA. 2, for the NPA, the patient must be semi-responsive. So the patient must be semi-responsive or semi-conscious. There must be a gag reflex present. So semi-responsive gag reflex must be present. However, the patient is still having ventilation problems. So the chest rise is not adequate. That's the indication in NPA. Semi-conscious, no gag reflex, or chest rise. The rules for using airway adjuncts. Use OPA only on patients not exhibiting gag reflex. Open patient's airway manually before using adjunct device. When inserting airway, take care not to push the patient's tongue into the pharynx. Have suction ready. So when you're going to manage a patient's airway, there are certain equipment that must be accessible to you. And whoever is going to manage the patient's airway need to be at the patient's head. Now, the equipments that you need to be accessible to you, airway adjuncts must be accessible. BVM or pocket mask, oxygen source, suction machine with either a rigid or flexible catheter and pulse oximetry, and if available, end-tidal CO2 monitoring. When you're going to use the NPAs, when you're going to use them, you should have at least 2 to 3 sizes. So if it's an OPA, you should have at least 2 to 3 sizes. One that you think will fit, one smaller, one larger, right? It should be available to you. But the NPA is the same, 3 sizes, one small, one larger, one that you think is the appropriate fit. It can be 2, it can be 3, right? But you should have more than one available. All right. So have suction ready prior to inserting an airway. Do not continue inserting airway if the patient gags. So if you're inserting an OP and your patient starts to gag, don't continue to insert. Turn the head or turn the patient as a unit once that's possible. If it's not possible, then you have to suction while pulling out. Maintain head position after adjunct insertion. Monitor airway. Continue to be ready to provide suction if fluid or blood obstructs the airway. If patient regains consciousness or develops a gag reflex, remove the airway immediately. Now, once your patient starts to gag on the airway or regain consciousness, if as long as it is appropriate, turn the patient's head to the side or turn the patient as a unit. If you are not able to turn that patient's head to the side or turn the patient as a unit, suction the airway first before pulling the adjunct out. So suction while pulling out of the patient's airway. Yes, Miss Cephas.
Sir, what happens if the airway is swollen, like the trachea? You can't use.
We don't come
Can't
to
breathe.
that bridge yet. We don't reach that bridge yet. We still are creep. You'll get to that. So that's not that's a good question, but I'm not gonna answer that yet. So use infection control practices while maintaining the airway. Oropharyngeal airway. Device used to move tongue forward as it curves back to the pharynx. We have infant to adult sizes. This is what the device looks like. That's an oropharyngeal airway. In measuring, we measure from the corner of the mouth to the earlobe or angle of the jaw. So it's a corner of the mouth to the earlobe or angle of the jaw in the position of function. So this is what we would consider the position of function. How the device will fit when inserted correctly. This is how you're going to measure. On the next slide, this is unacceptable. So this is incorrect measurement. This is not position of function. If you do this, when I'm evaluating you for this particular airway adjunct, you will fail. So when you're measuring a shoes for your foot, you don't turn the shoes the opposite direction, right? It must be aligned in the same direction of the foot. It's the same thing with the airway. You turn in the opposite direction, you cannot measure it properly. Let me see that happening. This is what we want. Position of function. Now, when you insert the airway adjunct, you will insert towards the hard palate. So you're inserting it in this direction, towards the hard palate. Once you touch the hard palate, you will rotate 180 degrees. Right? You can utilize your cross finger technique to create more space. Insert towards the hard palate. Once you touch the hard palate, you rotate 180. Now, if the patient's tongue or soft tissues might be inflamed, you may have to use or try using a tongue depressor to move the base of the tongue and then insert the airway device. And we will go through all of that in skills. All right, now inserting the OPA. So if you're gonna do it with direct insertion, meaning you don't rotate 180, you must use a tongue depressor. You can also use the tip of the suction catheter, which is a better option because you can, if you need to, right away you can create suction to clear the airway and then pass the airway adjunct, right? So that would be the preferred field method in pre-hospital care, using the rigid suction catheter as a tongue depressor. Nasopharyngeal airway, soft, flexible tube inserted through the nostril and into the hypopharynx. Moves tongue and soft tissues forward to provide a channel for air. Can be used in patients with intact gag reflex or clenched teeth or jaw. Contraindicated if you suspect a skull fracture. Now, there are protocols that will say once it's a trauma patient, unresponsive trauma patient, the NPA is contraindicated. We cannot use. It's too risky. We're not able to determine if the patient has a skull fracture. And if there's a skull fracture, you can push the NPA through that opening in the skull into the brain. And we don't want that happening. So it's definitely contraindicated for any patient that you suspect has a head injury. But there's a standard protocol that says once it's a trauma patient that's not responding, it's contraindicated. Come in various sizes, must be measured. Typical adult sizes 34, 32, 30, and 28 French. Inserting the NPA, we will measure from the tip of the nose to the earlobe, tip of the nose to the earlobe in the position of function, how it will fit when inserted. The top portion here is the flange, the mid portion is referred to as the stem, and the opening is the navel. You need to lubricate before insertion. The opening, when it is being inserted, the opening at the tip or navel should always be pointing towards the septum. So the opening should always be pointing towards the septum. The septum is the mid portion of the nose. All right, now suctioning. Suctioning. Obvious liquids, blood, secretions, vomitus must be removed from the airway to prevent aspiration in the lungs. Use vacuum device to remove liquids from the airway. Now, if you're approaching the patient and you can hear gurgling or bubbling sounds, it's obvious that something is inside of the patient's mouth. It wouldn't be logical for you to position that airway and check. You already know that something is inside of the patient's mouth, and that's fluid. If you open the airway with fluid inside of the mouth, that's going to go inside of the patient's lungs. So once you can hear gurgling or bubbling sounds, the first thing you need to do, once there's no issues present to prevent that, is one, turn the patient head to the side or turn the patient as a unit. So you turn the patient head to the side or turn the patient as a unit. If that is not possible, then we're gonna have to advance suctioning and the airway adjunct at the same time while we're positioning the airway. Right, so once you can turn the head or turn the patient to the side, do so. Then you need to get your suction device ready with the assistance of your partner. Choose the most appropriate suctioning device. If it's a large amount of secretion, then the most appropriate suction catheter would be the rigid or Yanker tip catheter. If it's minimal secretions, the patient has clenched teeth or fluid coming from the nose, then you'll need a flexible suction catheter. Now, when you turn your patient head to the side or turn the patient as a unit, ensure that you can see what's coming out of the patient mouth. You may have to use your gloved finger to remove chunks because you cannot suction chunks. You may have to remove chunks from the airway. Now keep in mind the airway management can get very messy. So be prepared for that. Excuse me. So suction devices, you have three types. You have your fixed suction unit, which is on the ambulance. You have your portable, which uses a battery. That's one that you can take to the patient, turn it on, use it. And you have your manual suction, which really don't use that much anymore in the field. I was back in the days and it wasn't that useful at all. The mounted suction systems installed near head of stretcher furnish air intake of at least 30 liters per minute, generate vacuum pressure of no less than 300 millimeters of mercury when collecting. Tube is clamped. So you want a suction pressure of no less than 300 millimeters of mercury. So you need to be familiar with the suction device that you're using. The portable suction unit, same requirements as mounted, oxygen or air powered, or powered by batteries, electricity, or manual. Tubing tips and catheters. Tubing, you have your suction tips, suction catheters, collection container of clean or sterile water. All of this we'll go through in skills. This is a fixed unit or mounted unit. Tubing tips and catheters, rigid pharyngeal suction tip, that's a Yanker tip, large bore than flexible catheters. So the Yanker tip is used when there's a large amount of secretions that is coming out of the patient's mouth. That's what that looks like. The rigid pharyngeal suction. Yes, Mr. Smith. Okay, continuing. Rigid pharyngeal suction tip, suction only as far as you can see. Do not lose sight of distal end. Careful insertion helps to prevent gag reflex or vagal stimulation. Right? So if you go too far down to the back of the throat, it can stimulate a gag reflex, or it can stimulate the vagus nerve, which is the 10th cranial nerve. This is a nerve that controls your heart rate. If the vagus nerve is stimulated, it will slow down the heart. That's not good for your patient, especially one that's not responding. Flexible suction catheters, designed to be used when a rigid tip cannot be used. Can be passed through a tube such as the nasopharyngeal or endotracheal tube. Can be used for suction in the nasopharynx. They come in various sizes identified by a number, French, larger the number, larger the catheter, right? Don't get too caught up on numbers, just look at the size of the patient nostril and you use the most appropriate NPA that will fit based on the size and measurement. Flexible suction catheters, not typically large enough to suction vomitus or thick secretions, making, in event of copious thick secretions, consider removing tip or catheter and use a large bore rigid suction tubing. Right. Flexible suction catheters measured in a similar way as the OPA. So, and get in the habit of measuring it, whether it's flexible or rigid. Let that be a habit. Measure in similar way as OPA, length of catheter that should be inserted into the mouth equals the distance between the corner of the patient's mouth and earlobe. So you're going to measure the same way as you would for the OPA. Techniques for suctioning: use appropriate infection control practices while suctioning. They definitely need to ensure that you protect your eyes, your mouth, and your nose. You should not be doing upper airway management without goggles and a mask. That is a must. Now, suction no longer than 10 seconds at a time. Now, in your Jones and Bartlett textbook, it's 15 seconds for an adult, 10 seconds for the child, 5 seconds for the infant. If it is an advanced airway, you don't exceed 10 seconds. But a general rule, try not to exceed 10 seconds. Prolonged suctioning can cause hypoxia and bradycardia. So that's a decrease in oxygenation, that's hypoxia, and a slowing down of the heart below 60 beats per minute would be bradycardia. If patients vomit for longer than 10 seconds, they may require continuous suctioning. And if you're going to do continuous suctioning, then you should have a oxygen source on the patient. So place tip of catheter where you want to begin suctioning and suction on the way out. So you suction while coming out, you don't suction going in. Right? So once you get to the liquid, create suction, move side to side or in a circular motion out. There are some airway adjuncts in which a suction catheter can be passed through the OPA. Right now, keeping an airway open, definitive care. Very important. Keeping the airway open may exceed capabilities of a basic EMT. So it may exceed your capabilities. So I come back to the question now that Ms. Cephas had asked earlier. So Ms. Cephas, repeat that question for me. You had asked something about swelling. Repeat the question.
Yes, sir. I was asking what protocol would you use if the trachea or just the airway is swollen?
All right. So if the patient has upper airway swelling, there's nothing you can do as an EMT. Absolutely nothing. And that is why we have both BLS and ALS response system. Right? So in Jamaica, if you get that type of patient, if you cannot get them to the hospital quickly, that patient is going to die. In the States, an EMT would recognize that that's an ALS call. So they would have requested ALS early because what is now needed for that patient is a surgical airway. The patient is going to need a surgical airway, and that cannot be done at the EMT level. So you're looking at paramedic level or higher. So that's the answer to your question. So if the ear passages the upper airway passage above the larynx is completely swollen, there's nothing you can do as an EMT for that patient. ALS response would be needed at that point. So keeping the airway open may exceed capabilities of a basic EMT. Medications or surgical procedures may be necessary to resolve airway obstruction. That's a cricothyrotomy or needle cricothyrotomy or surgical. So the patient is going to need a surgical airway. Nobody really wants to do that, but we may get to that point in the field. Rapidly evaluate and treat airway problems. Quickly recognize when more definitive care is necessary. Pay attention. So, I don't know where we have this notion in Jamaica that is only BLS we need. I do understand that before ALS is implemented, we must have a good BLS structure, but there will be ALS calls. You're going to have patients that require ALS procedures. It's going to happen. If ALS is not available, it's going to come down to how fast you can reach the most appropriate healthcare facility. Most appropriate. Right? So most appropriate. So if a patient is involved in a motor vehicle accident in a halfway tree, right? The closest hospital is probably medical associate, but the patient has significant airway compromise, at risk for the airway swelling shut. Based on the nature of the patient injuries, medical associate would not be appropriate. UE would be more appropriate, right? So these are things that you will have to consider when you are in the field. All right, now think about it. If you are not able to manage an airway at the basic level, what advanced resources might be available to you? Miss Cephas.
If I was not able to manage an airway at the basic level, I'm not sure how to answer that question because.
What do you mean you're not sure? Remember, Miss Cephas.
Because if I'm not able to manage it, like I don't have the.
Hold on. Listen clearly. You're not doing a Jamaican EMT course. The questions that you will get in your exam are not based on Jamaican EMS. So I'm going to ask the question again. If you are not able to manage an airway at a basic level, what advanced resources might be available to you? You still don't know?
No.
Okay. Yes, Gavin, go ahead.
Morning, sir. Would it be that you have to call your online medical director, sir, so for them to give you the advanced treatment to proceed?
Apart from medical director, who else you gonna request?
The ALS team.
ALS response. What else you need to do as it relates to the receiving facility?
Find the best nearest facility that would have the resources for that patient.
Right, and you need to notify that facility what you're coming with. Right, so you have to inform the facility that this is what you're coming with so they can prepare. I'm not asking difficult questions, right? All of the answers to the question is in the presentation. Think as if you are in a first world system. You're not gonna get questions based on what exists in Jamaica. nothing exists. All right. So special considerations. Facial injuries frequently result in severe swelling or bleeding that may block. Frequently result in severe swelling or bleeding that may block or partially block the airway. Bleeding may require frequent suctioning or more definitive airway management. Mr. Powell, if you have a patient and that is unresponsive, upon approaching that patient, you can hear gurgling or bubbling sounds coming out of the patient's airway. What would be the first thing that you do for this patient?
The first thing would be if the patient has no injury that could prevent me putting the patient on the side to clear like the fluid that's blocking or that may obstruct the patient airway. I can do that, or if that's the case where I can't move the patient, it will be suction.
You're gonna move the patient once you can. That's what you said, right?
Yes, sir.
All right, good. All right, now obstructions. Many suction units are not adequate for removing solid objects. Objects may have to be removed with manual techniques, abdominal thrusts, chest thrusts, finger sweeps. Airway can get messy. Make sure you're prepared for it. Dental appliances. Leave in place during airway procedures when possible. Partial dentures may become dislodged during an emergency. Be prepared to remove if airway is indeed. So if it's firmly in place and you can work with it, you work with it. If it's not firmly in place, then it has to be removed. All right, now some pediatric anatomical considerations. Some points that you need to note for your pediatric patient. Open airway gently. Do not hyperextend the neck. You want the head in what we would consider to be the sniffing position because their air passage is tiny, right? Size of a straw. Consider adjuncts when other measures fail. Use rigid tip with adjunct, but do not touch the back of the airway. So their vagus nerve is easily stimulated. So be careful not to go too far to the back of the patient's throat. All right, chapter review. The airway is the passageway by which air enters the body during respiration or breathing. A patient cannot survive without an open airway. If you don't have an airway, nothing else matters. Airway adjuncts, the oropharyngeal and nasopharyngeal airways can help keep the airway open. The indication for the oropharyngeal airway, patient must be unresponsive, no gag reflex, or chest rise. Indication for the nasopharyngeal airway, patient must be semi-responsive with a gag reflex present for chest rise. It may be necessary to suction the airway or to use manual techniques to remove fluids and solids from the airway before, during, or after artificial ventilation. And we will talk about artificial ventilation in the next chapter. Remember, always use proper personal protective equipment when managing an airway. Make sure your eyes are protected, cover your nose your mouth. Airway assessment must be ongoing, an ongoing process. Airway status can change over time. Airway management should start simple, and become more complicated only if necessary. So you always start with your basics, right? And then as things become more challenging, you move up the ladder. Questions to consider. You should be able to name the structures of the airway. You should be able to explain why care for the airway is the first priority of emergency care. You should be able to describe the signs of an inadequate airway. So let's go with the first two, because some of you might not be able to name all of those structures yet. Who can explain why care for the airway is the first priority of emergency care? Want to take that one? Ms. Wellington. Ms. Wellington, that question is yours. Are you present? Go ahead, unmute your mic, answer the question.
Sir,
Yes?
care for the airway is important because if the airway is not care, if you do not provide care for the airway, the patient is at risk for dying. So that's why it's very important. You have to be breathing to be alive.
All right. Ms. Wellington, are you still using your phone?
Sir?
That's a question. Are you still using your phone to access the platform?
No, sir, not this morning. I'm currently using my tablet.
Okay. I didn't hear anything you just said. So go ahead and type in the chat what you just said. Use your mic.
Okay, sir.
Anybody else want to answer that question? Ms. Lewis, are you present? Ms. Lewis, are you present? You still having mic issues?
Can you hear me clearly?
Yes, I can. Go ahead.
Sir, well, to ensure that the person can breathe adequately. Because
That's a very vague response, and there is no confidence behind what you're saying. Your response is very vague. What do you mean by ensure that the patient is breathing adequate? Still on you, Miss Lewis. I'm waiting. What do you mean by the patient is breathing adequate? Yes or no if you have a response for me. Mr. Johnson, go ahead.
Yeah. Morning, sir.
Morning.
All right. In reference to ensure we have a proper airway for the patient or casualty, is that the body need oxygen to keep the organs alive and also the brain. So we have to ensure that one of the first thing we jump on and then we check on the circulation side of things.
That is acceptable. I will accept that. Right. Right. Go ahead and mute your mic, Mr. Johnson. Who was it again? I think it was Wilson. Michael Wilson had his hand up. Was it? Or was it? Yes, I think so.
Yes,
Go
sir.
ahead.
Basically the same thing that Johnson was saying. Cells need the process. Body need the process of perfusion to be adequate in order for the cells to survive. Without perfusion taking place, the cells of the body are gonna die, and inevitably the patient are gonna die.
Okay. The Cephas, you had your hands up.
Yes, sir. He already said what I was going to say. So.
Put it into your words and express it. So let me hear it in your words.
All right. So I'm saying, take patient caring for the airway is number one priority, because if you find somebody on a scene and they're bleeding out, you still have to check their airway, because the person could be could not be responsive and bleeding out. They could possibly still be dead, and you wouldn't know, and you'd be taking care of the blood loss while you're actually, caring for somebody that wouldn't make it anyway. So checking if the airway is clear, and that would just be the first priority.
Hey, I hear you. I hear you. I hear you.
Hear me?
Yes, that's reasonable. All right. Yes, Mr. George. Go ahead.
Mr. Morris here, sir. Morning.
Oh, Mr. Marks, go ahead.
So the body needs oxygen to survive, and the airway is the only way that oxygen enters the body. So that's basically it in a nutshell, sir.
Okay. Reasonable. All right. So remember, so last week we were creeping. This week we start to walk. The pressure meter is gonna go up. You will be pressured in this course, and it's one out of two things will happen. You see that the pipe is going to burst. That means you realize that this course is just not for me. I can't manage this. Or you'll become diamonds. That is what I want. I want diamonds. Diamonds are made under pressure. Diamonds are made under pressure. So that's what I'm looking for. So prepare for that level of pressure to increase. We're walking now. Next week, we're going to start running. You have to be able to keep up. And you have to ensure that your connection is good. If you're in and out, you're going to have problems. You have been warned. If you're in and out, you will have problems. And I have absolutely no issues failing a student. It's easy for me to do once a student has not met the criteria for the course. Ensure that you're ready to do the work. All right, let us continue. So, well, let me not go there. Don't go there right now. We'll leave that one. The signs of inadequate breathing. Explain when the head tilt chin lift maneuver would be used and when the jaw thrust maneuver should be used to open the airway. And why? And why? Who want to take that question? Explain when the head tilt and jaw thrust maneuver is indicated and why you need to perform these tasks. Yes, Mr. Terrell.
Hello, sir.
I can hear you.
Yes, sir. So the jaw thrust should be used when there is a suspected spinal injury or spinal injury, and the head tilt chin lift should be used when there is no spinal injury. Do you hear me, sir?
Yes, I can hear you. Your background is a bit noisy, but I can hear you.
Yes, sir. So so you hear me?
Yes, I can hear you, but your background is a bit noisy.
I'm having a bad connection.
All right, go ahead and mute your mic.
Okay, sir.
All right, anybody else? Anybody else? Yes, Mr. Manning, go ahead.
Okay, sir. Morning again. All right. So the head tilt chin lift should be used when there is no sign of spinal injury. Well, these are used basically when the airway is blocked. The patient is unresponsive, so the tongue relaxes and all of that and blocks the air passage. So you'd use the head tilt chin lift to when there's no suspected sign of or you don't suspect spinal injury. The other one, which is the jaw thrust, you'd use that one if there's any sign of or you suspect spinal injury.
Okay. All right, that's acceptable. All right, so the next one. Explain how airway adjuncts, or question to consider. Explain how airway adjuncts and suctioning help in airway management. How would suction and the use of airway adjuncts benefit the patient? Yes, Michael Wilson, go ahead. Mr. Wilson.
Okay, sir. So airway adjuncts are used to maintain the open airway. So once you begin airway management, whether I use either the jaw thrust or the head tilt chin lift, depending on the condition of the patient, whether you suspect a spinal injury or there's no suspected spinal injury, you will need to maintain the airway, as in maintain it open. So the airway adjuncts are used to do that so that you can use other apparatus or other instruments. Suctioning helps in cases where either the patient is suspected that fluid may pose a danger to the airway, like a patient aspirating. So you'd use this suction to remove the fluid so that it don't pose additional threat to the patient.
That's reasonable. Yes, Miss Wellington, you have your hand up. Go ahead.
Can you hear me, sir?
Yes, I can.
Airway adjuncts are good to use during the course of respiratory difficulties to clear the airway to prevent aspirations.
Okay. What is aspirations?
Aspiration is when the patient is choking and vomit or blood or fluid is in the lungs, in the lung.
All right.
That causes difficulty to breathe.
All right. Good. That's reasonable. That's reasonable. Mute your mic. All right. All right. Critical thinking now. So this is an important one. Critical thinking. On arrival at the emergency scene, you find an adult female patient with gurgling sounds in the throat and inadequate breathing, slowing to almost nothing. How do you proceed to protect the patient's airway? Yes, Miss Cephas, go ahead.
Okay, sir. Because she's gurgling, then I would suspect that there is fluid in her lower, um, her lower airway.
Upper airway.
So I would, or upper airway. Sorry. So I would use suctioning to remove fluid from.
Is suctioning the first thing you would do?
Well, I would. At first, you'd have to measure her oropharyngeal. That's the word. That's how you pronounce it.
Oropharyngeal airway.
Right. So at first, I would measure that, then carry on the process, and then remove the fluid from her airway.
I don't quite. I'm not gonna fully accept that response. I wouldn't accept that response. You're missing something very important here. Anybody else? Anybody else? There must be a sequence to your management. Yes, Mr. Smith. Mr. Smith.
Sir.
Yes.
All right. So you the patient unconscious, sir?
Sorry?
Did you say the patient is conscious?
I can't hear what you're saying. You know.
That's all right, sir. Is the patient... Sir, I'm asking if the patient is unconscious or conscious.
I'm gonna understand why you asked that. The question is on the slide. On arrival at the emergency scene, you find an adult. Listen. On arrival at an emergency scene, you find an adult female patient with gurgling sounds in the throat and inadequate breathing, slowing to almost nothing. Based on what is up there, what is your management?
All right. So first, I will proceed by asking her if she's okay. Based on a response, we can determine whether or not the airway is completely blocked or partially blocked. If she's conscious, and it's blocked, I'll probably do a seal it maneuver.
What?
Depends if the person is okay, sir. Let's say inadequate. A seal it maneuver.
Static maneuver, that's what you said?
Seal it maneuver.
Philip, what is he saying? Philip or Selic maneuver, what are you saying?
Selic.
Is that with an S?
Yes, sir.
That's in your EMT course? Is that a part of your EMT scope of practice? to do a Selic maneuver, if that's what you're saying. And what would be the purpose of that maneuver?
Person is stroking, sir.
So what is the purpose of the Selic maneuver?
To clear the airway.
That's what a Selic maneuver is used for?
Yes, sir.
You sure about that?
Yes, sir.
That's incorrect. Yeah. So I would suggest you drop that one. All right, anybody else? It's a simple question. Yes, Mr. Manning.
Yes, sir. I'd like to give it a try. All right. So on arriving at the scene, firstly, you notice the patient is gurgling. The gurgling suggests that the patient has fluid in the upper airway, right? The
Yes.
patient should be tilted for the entire body to leak that fluid, depending on what's in or what's present in that situation, the upper airway, the mouth region. You might need a glove finger to remove the chunks if it's not just fluids only. After that, or if this doesn't work, then you would use suction to clear the airway. Once the airway, you have to clear the airway of the fluids. Once the airway is clear, then you would implement airway adjuncts to maintain that airway, so open it and have it maintained.
Right, that sounds sequential. That I can accept. So yes, that's fine. So you suspect that, who is that? Miss Wellington, go ahead.
I'm just giving it a try. You
Nothing wrong
realize
with
that the patient, sir, is having gurgling sound is coming from the patient. That means that the patient is having respiratory difficulties. In a case like that, sir, you would assess the patient to find out to see how best you will proceed with clearing that fluid from the patient lungs, sir. So you can either use if the patient doesn't have a spinal injury, you could use a chin maneuver, or if the patient has you suspect that the patient may have a spinal injury, you would use the jaw thrust maneuver, sir. In some also, sir, if the patient have if your patient any spinal injury, you could probably put the patient in a recovery position, use your index and middle finger to try to scoop out any thing that is blocking the patient airway.
All right, Miss Smith, I hear you. As I was saying before, your approach has to be sequential and it must be logical. You have a patient that is found. As you approach the patient, you hear gurgling sounds, and you can see that the patient's breathing is inadequate. So based on that presentation, two things are apparent to me, right? Two things. Patient has an upper airway problem and a lower airway problem, right? So it's very highly possible that the brain is being affected. Now think logical. If you have a patient with fluid in their mouth, would you want that patient to speak? Certainly not. So it would make it's not practical for you to ask the patient or to introduce yourself to the patient and ask the patient if the patient is okay. You do not want that patient to speak, right? Now, the first thing you need to do is address the fluid in the patient's airway. And the sequential approach to that is the first thing you will consider to do for this patient is turn the head to the side or turn the patient as a unit. Right? That's the first thing you could consider. Turn the patient head to the side or turn the patient as a unit so gravity can assist you while you get your suction devices ready to clear the patient's ear passage. Once you have cleared the patient's ear passage, then you reevaluate. This is where your re-evaluation come into play to determine the patient's level of consciousness and whether or not they have a ventilation issue that requires further management. It is a sequential approach that is required. That's one. Two, any maneuver that you're going to tell me about outside of this course, make sure you know what it is for. And if it's not a part of this curriculum, don't tell me about it. And if you don't know about the maneuver, I would advise you not to speak about it as well. Right? So, if you don't know about a particular maneuver or equipment, do not tell me about it. It's not a part of the course. Basic comes before everything else. And basics is what is going to save a patient's life. Basic is the difference, right? You have to start off with basic stuff before you start to get complicated. And you must have a sequential approach that is logical. Must be logical. What you're doing must be logical. Very important. All right, now next critical thinking question. When evaluating a small child, you hear stridor. What does this sound tell you? What are your immediate concerns regarding this sound? Want to take that one? Almost 10 o'clock? Wow. 3 minutes to 10. Anybody want to take that question before we take a break? All right. I'll go down the line. Yes, Mr. Patrick Wilson, go ahead.
For the first, oh yeah. I'm losing my. All right. So, sir, for this question, eventually, that will mean that there is an obstruction within the child's airway. So, my immediate reaction, sir, is trying to use the just method in order to see if there's a blockage inside of it. If there's a blockage inside of it, sir, I'll try to remove that blockage. I'll try to remove that blockage, sir, and after removing that blockage, I'll use if it cannot be used and there's liquid inside of it, I'll use a suction method, sir, to clear that airway, sir.
Oh, why are you doing a jaw thrust?
Alright, because first of all, sir, you wanna see what is inside of the child's mouth, and basically because if it is an infant or a toddler, sir, you'll want to know that, sir. So that's the reason why I'll use it. Because
I don't answer the question that I'm asking. What's the indication for a jaw thrust maneuver?
to see if there's any blockage inside of the airway, sir.
That's not the indication. So you're missing the mark by a huge number here. So
Okay,
you
sir.
need to know when your maneuvers are indicated. You're not demonstrating that now. So,
Okay.
all right. Anybody else? Miss Lewis. Miss Lewis,
Yes, sir.
talk to me. Strider in a child. What does this tell you? What are you concerned about?
I'm concerned about the blockage of the child's airway.
Which part of the airway, upper or lower?
Upper airway.
Okay. Why would you be thinking upper airway with Strider?
Because there, because
Right,
the
that question
sound.
might be a little too difficult, so we'll save that one for another day. The question might be a little too difficult. The Strider, asking you about the Strider. The other part of it is fine. Yeah, let me not ask.
I had an experience with it, in a sense, and it was really obstruction of the upper airway, of the nasopharynx. That sound
Okay,
possible. Right. So I kind of have an idea of this, what the sound is like. The experience was with my son. He had adenoid problem. So that
okay.
caused a high pitched sound in the upper airway.
You just answer the question, not with the technical part of it. Remember what I said, it's logical. If the higher the pitch of the sound, so the higher the pitch of the sound, the closer it is to the vocal cords,
Yes.
right? So it's a high pitch sound, very high pitch, very easy to pick up. The closer it is to the vocal cords, the higher the pitch. That is an indication of an upper airway obstruction or a partial obstruction of the upper airway. Miss Cephas, you had your hands up?
Yes, sir. I was saying it could also be a problem with the windpipe, and usually you would hear stridor through expiration. If the patient exhales, that's when you really hear it. And as she said, it has to do with obstruction
Okay.
somewhere along the upper airway.
Unlike your consult Google, man.
No,
In a Google consultation.
no.
Fine. Which is fine. Google can become your best friend. Anyway, all right. The last one. When assessing an unconscious patient, you note snoring respiration. Should you be concerned with this? And if so, what steps can you take to correct the situation? So you're assessing an unconscious patient with snoring respiration. What do you suspect? What are your actions to correct this? Who want to take that one? And this is the last one for this slide. Yes, Mr. Johnson, go ahead.
All right, yes, sir. With the snoring patient, this could be a patient who has a airway obstruction, or it can be a patient who is diabetic and
You see, hold on. Hold up, Mr. Johnson. You see anything in the question that says the patient is diabetic?
No, so when they happened to me one time, that patient.
Doesn't matter if
So
it happened to you with a patient. Answer what is presented. The question is asking about snoring respiration. What are you concerned about? What you tell about diabetic patient for?
All right, in tongue then, boss. In tongue,
That's the first thing you're supposed to be thinking about. That's it.
Right.
Now, if it is the tongue that is obstructing the airway, how are you going to get the tongue out of the ear passage?
Yeah, go open the area and put him in the recovery position, turn him on his side.
No reach recovery
So
yet.
it don't
You go open the airway. Which procedure would you use and why? You go open
I
the
use the
airway.
jaw thrust.
Your jaw
Hello?
thrust. Yes. It's a jaw thrust.
The jaw thrust to open the airway.
Or you can use what?
The head tilt and chin lift.
All right. What would be the indication for a jaw thrust?
Indication for a jaw thrust. If a person have any spinal injury.
Good. And the indication for the head tilt chin lift?
If them have spinal injury. No sign.
All right.
Of
No
spinal
sign.
injury.
So, who that are telling at the background? Who that talking to you in the background?
Hey, come on. Some people sometimes share a view. You know?
You think yes, them a born young man? Don't tell me about echo.
No.
All right.